Renuka Brado madam and Vijayalakshmi madam. Very happy to extend as external examiners in this session. And you all know that both of them are very good examiners as well as good ENT surgeons. Very happy to be, we are honored to have examiners in our session. And Dr. Pushpa, please, we can introduce our PG student also.
Hi, welcome Renu madam, Vijayalakshmi madam. Hi Febi, please introduce yourself. Febina. Hi Febina.
Febina, have you broken your fast or you're still hungry?
Febina.
No, I think the audio is muted. Let me see. പറ്റുന്നില്ല നേരത്തെ പോകാമായിരുന്നല്ലേ.
Febina is our third year JR in our Government Medical College Trivandrum. Febina. Where is she? Febina.
Febina, Dr. Febina, please unmute yourself. Dr. Febina, please unmute yourself.
Hello? Hello? Hello, ma'am?
We can hear.
Hello. Febina, please unmute yourself.
Yeah, I think she said she spoke. Dr. Febina?
Hello, hello?
Hello. Hello.
Dr. Febina, you can present. You introduce yourself and present.
I'm Dr. Febina from Trivandrum Medical College. I'm doing my third year residency. Present short cases.
1 minute, Dr. Febina. Is her audio clear for all of you? Because it seems to be.
No, it's breaking. It's breaking.
Febina, can you talk?
Don't log in from two devices. If you're logged in from two devices, also this problem will happen.
Febina, can you speak once more?
Hello. Is it audible?
Breaking. One second.
Hello. No, it's just audible.
Hello. Is it audible?
Okay, louder, please.
Hello.
Yes.
Hello, I am Dr. Febina, junior resident from Government Medical College, Trivandrum. Is it clear, madam?
It is better. Can she not come on video so we can see her as well? Yes, we can see you now.
Is the audio clear, madam?
Yes, it's clear now. How is it? Is it clear for all of you? Professor Vijayalakshmi?
Your voice is clear, but Febina's is fading on, off and on. It's not. Anyway, let her start. Let her start. We'll see.
Start, madam.
Yes.
presenting the case of Jalaluddin, 55-year-old male patient coming from Fluent. He is a farmer. He presented with complaints of change in voice for last 1.5 years. History of present illness. Patient was apparently normal 1.5 years back. Then he developed an upper respiratory tract infection followed by change in voice. And change in voice was progressive in nature with no diurnal variation. There was no aggravating or relieving factors. He gives history of voice abuse and recent onset snoring. There is no history of difficulty in breathing, noisy breathing, difficulty in swallowing, or painful swallowing. There is also no history of pain during phonation. There is no history of any evening rise of temperature, cough with blood in sputum, or cough while swallowing. No complaints of heartburn. No history of any trauma to neck or recent surgeries. No history of recent weight loss or any neck swellings. Coming to the past medical history, he has no non-comorbidities, no history of any surgeries in the past or any drug allergy. Personal history, he is a chronic smoker with a pack year of 6. And socioeconomic history, he has studied till 7th standard and he is a farmer by profession and he belongs to lower middle class family according to modified Kuppuswamy scale. Madam, can I proceed with examination?
One more thing that you need to ask, you ask for cough, but also, cough on lying down, cough at night. You said cough while swallowing. The other cough you should ask about is whether there's cough while lying down at night or in the night, and any sense of hawking or feeling of some foreign body sensation in the throat. But otherwise it is good. It's detailed history.
May I proceed with the examination part, madam?
Proceed.
Coming to examination, on general examination, patient is moderately built and nourished, conscious oriented. There was no pallor, icterus, cyanosis, clubbing, lymphadenopathy or pedal edema. ECOG performance status was 0. His voice was harsh and breathy with a maximum phonatory duration of 5 seconds. And his pulse rate was 72 per minute, BP 140/80 millimeters of mercury, and respiratory rate 14 per minute, and abdominothoracic. Examination of oral cavity and oropharynx. Mouth opening was adequate. Angle of mouth, lips, buccal mucosa and teeth was normal. Gingivo-labial sulcus, gingivo-buccal sulcus was normal. Hard palate, anterior 2/3 of tongue and floor of mouth was normal. Retromolar trigone, soft palate was normal. Uvula was central. Bilateral tonsils and tonsillar pillars was normal, and posterior pharyngeal wall was normal. And on indirect laryngoscopic examination, base of tongue, bilateral vallicular, median and lateral glossoepiglottic fold, and epiglottics, and ariepiglottic fold and arytenoids were normal. The left vocal cord showed a pinkish red smooth surfaced mass, which was broad-based with a broad-based pedicle arising from the superomedial surface of the left vocal cord, which was moving up and down on phonation and with a whitish area in the posterior surface. And the right vocal cord was normal, and there was dysphonia plica ventricularis. Glottic space was adequate, and bilateral pyriform fossa, no pooling. Examination of neck. External laryngeal framework was normal. Trachea appeared central, and the laryngeal crepitus was present. There was no cervical lymphadenopathy, no neck muscle tenderness, and thyrohyoid and cricothyroid space was normal. Ear examination, nose and paranasal sinus examination were normal, and systemic examination was also normal. Summary, A 55-year-old male patient who is a chronic smoker presented with complaints of change in voice for last 1.5 years duration, which was gradually progressive with a history of voice abuse. And on examination, his maximum phonatory duration was 5 seconds with left vocal cord showing a pinkish red mass with a broad-based pedicle in the supromedial surface of middle third of vocal cord, which moves on phonation and respiration with adequate glottic space. So my diagnosis is a left vocal cord polyp.
What is the normal NPT?
20 to 30 seconds, madam.
Is it different for males and females?
The range of 15 to 25 is set for females and 25 to 35 in males.
Why do you say it's a polyp?
Considering the age of the patient and the patient being a chronic smoker, and he also gives history of voice abuse, and the appearance in indirect laryngoscopy examination was a smooth surfaced polypoidal mass, and the location of the mass, which is in the mid-membranous cord, which is suggestive of a left vocal cord polyp.
How will you differentiate it from malignancy? Why do you think it's not malignancy and it's a polyp?
There can be an underlying malignancy considering the age and the patient being a chronic smoker, but the usual appearance of malignancy is usually a proliferative or ulceroproliferative growth, which is not seen here.
What would you look for on the other cord besides on the left cord? There's a polyp. Would you look for something on the right cord as well?
There can be a contact ulcer on the other cord, or any hyperkeratosis can also be seen.
You spoke to us about vocal abuse, but you didn't explain in detail what kind of vocal abuse. Very important. Do you think it's important to know the details of the vocal abuse?
Patient is used to talk a lot, excessive vocal, excessive usage of voice is there.
Is that called abuse?
Excessive use of voice is called as voice abuse, and a faulty technique of voice production is vocal misuse.
Overuse, right? Is it abuse or overuse?
Abuse is overuse of voice, madam.
Why is it important to know that? Why is it important to know the details of what he does with his voice?
Because phonotrauma is a major causative factor for vocal cord polyp.
Is it continuous overuse or voice, or it is something that happens all of a sudden?
It's a habitual vocal overdoer. That's what he said.
Febina, what is the reason in vocal cord polyp? That is what she is asking.
Phonotrauma, madam.
What happens?
Yes.
What exactly happens?
Vocal cord polyp, if the patient is having any acute infections, that time the vocal cord will be inflamed, resulting in the formation of a polyp.
What type of phonotrauma? That is what she is asking. What type of phonotrauma?
Vocal abuse, madam.
I think Madam wants, I'm not sure, but I think Madam wants to know whether there's constant overuse causing it, or can it be a single episode of yelling loudly?
Yeah. So is this a
Sure.
hemorrhagic polyp or, you know,
A single episode may have been a factor for this matter.
you also said that this patient has dysphonia plica ventricularis. So what is dysphonia plica ventricularis, and does it have any role in the causation of this polyp?
Dysphonia plica ventricularis means the faulty usage of false chord inphonation, and the development of polyp may have caused dysphonia plica ventricularis in this patient.
This patient doesn't have any LPRD, right? You said there is no history of heartburn.
No symptoms of heartburn.
What are the other symptoms you get of LPR?
Foreign body sensation in the throat, then nocturnal cough, then change in voice are the main symptoms of LPR.
It is LPR. Can LPR be a causative factor also in polyps?
Yes, madam. Can be a causative factor.
Can you tell us the pathology of how a polyp is formed?
There will be inflammation of the cord resulting in protrusion of the there will be protrusion
Little
of
louder. We can't hear you clearly.
there will be protrusion of the subepithelial stroma through the inflamed mucosa, resulting in the formation of the
There are some words associated with it. First there's edema, then there's something, then there's something. There are words associated with it.
You'll have to specifically say what happens following repetitive trauma. This patient has been repetitively, according to you, he's been misusing his, or overusing his voice for a long time. So repetitive trauma, what happens after that? So there are certain steps that you say which occur in the formation of the polyp. That's what I think madam wants to know, that because
Yes,
that is the pathogenesis of a polyp.
Yeah.
after repeated phonotrauma, there will be inflammation of the mucosa, and subepithelial infiltrates may come to set in.
Are we allowed to tell them what we are asking, the answer to what we are asking, or we should not tell them?
Yes, ma'am. Yes, ma'am. Sure.
Okay. So there is increased, there's angiogenesis. There are more blood vessels coming there. And there is highness. So after some time, after edema and new angiogenesis, then you get hyalinization of the stroma. These are the two things that can happen.
That also you need to know pathologically. When you say there are 3 different types of polyps,
Yes.
they classify them into hyperplastic polyps, hemorrhagic polyps, and sessile polyps. So you should know each one of them distinctively. So in the hyperplastic polyps, you typically have hyperplasia of the epithelium, and stromal changes like fibrosis and inflammation. In hemorrhagic polyp, you have blood within the trauma. So that is something which, blood within the stroma. So that is typically because a single bout of shouting that can cause a hemorrhagic polyp. And you have the sessile polyps which have a broad-based attachment.
How do you differentiate a polyp from a vocal nodule?
Vocal nodule will be usually bilateral. It will be broad-based. Whereas the polyp will have a pedicule, usually a pedicule.
Yes, go on.
And the surface will be smooth in nodule. As in polyp, it can be smooth surface or polypoidal surface.
What age group, gender do they generally occur? There can be exceptions, but generally what age group and gender do they occur in?
Vocal nodules, madam.
Yes.
Usually in females of the age group of 20 to 30 years.
And children also.
Children also.
And polyps?
Polyps usually occurs in the age group of around 40 to 50. Usually in smokers, in males and
yes.
males.
So your patient is correct. He's a male, he's a smoker. He has vocal abuse. How will you investigate him?
First, I would like to do laryngoscopic examination and stroboscopic examination for this patient to confirm.
What type of laryngoscopic examination? There are lots of different types of laryngoscopic examinations.
Flexible laryngoscopic examination.
What is the other type you can do?
Rigid laryngoscopic examination can also do.
Rigid laryngoscopy. What is the limitation of rigid laryngoscopic examination?
The phonation pattern cannot be made out using a rigid laryngoscope.
Okay, go on with your investigations. What are you saying?
To confirm my findings, I will first do laryngoscopy along with stroboscopy examination. After confirming findings, I would like to explain the nature of the disease and the lesion of the patient.
What do you expect to know in your video stroboscopy in this case? What do you expect to see?
Usually in vocal cord polyps, the mucosal waves will be reduced.
I mean, does it add any value to your treatment plan? Does video stroboscopy, is it going to add any value to your treatment plan? In any way, is it going to modify your treatment plan, or how is it going to help you?
You can exclude any infiltrative lesions like malignancy.
What happens in malignancy?
In malignancy, the mucosal wave will be absent.
Which other conditions, benign condition, can the mucosal wave be disturbed?
In vocal cord cyst, it can be absent.
What is the appearance? What does it look like? Looks like a boy, B-U-O-Y, boy, bobbing on the sea. That's the appearance of a vocal cord cyst on stroboscopy. Is the
Fibina, please
mucosal
talk
wave affecting
loudly.
vocal?
Okay.
Madam is asking a question, I think.
No, Fibina, please talk loudly.
Okay, madam.
What is the mucosal wave? What happens to the mucosal wave in vocal nodules?
It may be reduced, madam.
Is it reduced?
Sometimes it can be normal.
Is it present or absent? In vocal nodules, is the mucosal wave present or absent?
Absent.
No, it will be present.
Fibina, in which benign condition you get the absent mucosal wave?
For cyst.
Okay.
What will happen to the amplitude of the wave?
Vocal polyp, it will be reduced.
Suppose you have to describe a voice. Can you use any scale?
Can use GRBA scale.
What is GRBA scale? Can you tell us?
GRBA is G grade, roughness, breathiness, asthenia, and strain.
How do
So
you
how
grade? What is that G grade?
Grade is the amount of harshness or the grade of dysphonia the patient is having.
Grading is based on what? So it is based on how impaired the listener perceives the voice to be, right? It's the grading is done by the listener. So overall severity or the degree of voice issue that the patient is having, the listener will grade into from 0 to normal. I mean zero, where 0 is normal, 0 to
3?
I think 3, where
Yes,
that is
3.
the
So grade, roughness, what were the others?
Breathiness, asthenia, and strain.
Each of these is
Is
actually rated on 0 to 3 scale. Each of the parameters is rated.
How does this scale help?
Scale will help to know about the degree of dysphonia the patient is having.
Also, you can make out whether there's any change with speech therapy, whether there's change post-surgery. You will grade it again, right?
It helps you in assessing response to treatment as well, right? You got the point?
Yes, madam.
So what are the objective ways to evaluate voice quality?
Rabina, please speak loud.
The method we can use, the stroboscope we can use.
You heard of acoustic analysis of voice? Yes, stroboscopy is one of the ways. What is acoustic analysis, you know?
Details, I don't.
I couldn't hear what you said.
I don't know the details, madam.
Okay.
Patient, surgical excision is warranted. So I will counsel the patient regarding for a surgical excision of the lesion. So for that,
is there
I
any
will
role of
send
speech therapy in vocal cord polyps?
there is role for speech therapy for such a big lesion. Surgical excision is mandatory.
Agreed.
Surgical
Besides
excision
surgical,
followed by
Voice therapy.
so there is a role, right? Even though you don't use
Yes.
it to treat the polyp, after the polyp is removed, you have to, the patient has to undergo, he must understand vocal hygiene, must learn how to use his voice correctly. So speech therapy will come after the procedure.
but you'll have to counsel pre-operatively, otherwise that he will need therapy after surgery. You will have to counsel pre-operatively, right? You said you
Yes.
will counsel the patient regarding the need for the surgery and the procedure, but you'll have to counsel for the post-operative voice therapy that you will require also pre-op itself.
Yes, ma'am.
What surgery will you do?
Laryngoscopy and excision of the colon under general
You'll
anesthesia.
just catch the polyp and remove it?
A microlaryngeal surgery is needed.
A microlaryngeal
Agreed,
surgery,
it's
of course, but you'll
microlaryngeal
just pull the
surgery.
polyp. You'll just pull the polyp like how you pull the tonsil, and you'll cut it off, or what will you do? How will you do it?
Using a microflap technique will be excised.
So what are the different types of microflaps?
Medial microflap technique, a lateral microflap technique, and mini microflap.
Can you explain what they are?
In lateral microflap technique, the incision over the vocal cord is made somewhat lateral to the lesion, and the flap is elevated, stiff, and the lesion is excised. And in medial microflap technique, the incision is put nearer to the lesion, whereas in mini microflap technique, the incision is put over the lesion.
At the junction of the
Into the epithelium.
lesion and the normal cord. And then what will
So
you do
what
once
are
you've
the
taken the incision?
okay.
Sorry. Can you repeat the question?
I said, what will you do after you've taken the incision?
After taken the incision, raise the flap and separate it from the vocal ligament, and the lesion is completely excised from beneath the epithelium, and the redundant epithelium is draped back.
So, what are the advantages of this microflap technique in vocal polyp excision?
There will be no injury to the vocal ligament. So there will be no scarring and the voice will be good after the excision.
What exactly are you trying to preserve?
Causal wave pattern can be preserved by keeping.
So can you tell me why who first described the microflap technique? Do you know the name of the doctor who first described that microflap technique? Someone called Sataloff. Sataloff first described. Can you tell us why the lateral flap is not done now, and preferably you do a mini microflap? There is a certain reason why.
The lateral microflap technique, so much of epithelium sized compared to mini microflap technique, and also chance of injury to vocal ligaments more.
There's something you may do it very well and not damage the vocal ligament. There's some very specific thing which was discovered. And then after that, they realized that it is better to keep the incision as close to the polyp as possible. Because even if you do a lateral microflap, you can dissect very precisely and make sure that you don't damage the SLP very much while doing it, superficial lamina propria. So you can do it, but they discovered something. It's a little detail because you must have read up, no, for this. That's why I'm asking. Are there some loops that you have read about? So there are certain loops. Maybe you can look it up in detail later on. There are certain loops which go from the basement membrane to the superficial lamina propria. And they are of collagen, the anchoring loops. So you can damage these, a large number of these loops while taking off with a lateral microflap. So in order to preserve these collagenous loops, it's better to not raise very large flap. Read it up. It's there. Okay.
So, what advice will you give the patient post-op apart from voice therapy? What other advice, what lifestyle modification, and all that you will tell this patient?
The immediate post-operative period, patient will be advised voice rest and absolute voice rest for first 48 hours and voice rest for next 1 week. And patient should be advised regarding quitting of smoking.
So, when will you start the voice therapy then? After 1 week or after 2 days? You said 48 hours absolute voice rest. So, when will you start voice therapy for this patient?
After 2 weeks, madam. Hello?
Continue.
After 2 weeks, madam.
You think the patient will...
Febina, keep your mic closer to your lip, otherwise they are not hearing well. Huh?
Okay.
Okay, what
Yes,
else will you
answer
advise the
what
patient?
madam had asked.
For adequate hydration, then to quit smoking and patient will be given proton pump inhibitors for around 6 weeks.
Anything about meals?
To avoid spicy food.
Anything else? About the frequency?
Take short, frequent meals.
Small frequent meals.
Small.
No whispering, no talking with background noise going on.
Why do we advise the patient not to whisper? Generally, any voice surgery we do, we tell patients not to whisper, right? Why?
It is inside the vocal range. Hello? Hello?
Yes, we can hear you.
Hello, madam?
What is the normal range of speech? What are the normal frequency range? About 100 to 120 hertz. Okay, in men. Women is, they say, an octave higher about. We're not talking about Lata Mangeshkar or Amitabh Bachchan. We're excluding them, but otherwise it is 100 to about 120. Madam, do we continue or we move to the next case?
We can move to the next case. Madam, Pushpa madam, Jayaprabha madam.
Yeah.
Thank you,
Any
Febina.
other exam process are there in the group? Anyone can ask question. Dr. Shibu was there. Venu sir was there. Anyone can ask question.
Okay, good evening.
Good evening, Shibu.
Good evening, JP. Febina, when you were presenting, Febina, you
Yes, sir.
told indirect laryngoscopy finding, you told there was dysphonia plica ventricularis. I never understood that. What is that?
Sir, it's a faulty usage of false vocal cords for phonation.
Yeah. So that's not an indirect laryngoscopy finding. Okay. That is your diagnosis. Indirect laryngoscopy, you can say there is hyperadduction of vocal cords, or there is partial or complete closure of the ventricular band, I mean, false vocal cords, or partial or complete closure of the false vocal cord. Don't see this, there is dysphonia plica ventricularis. It is a completely different entity. Again, you told dysphonia plica ventricularis may be due to the vocal cord polyp, isn't it? Due to the explanation you were telling, that false cord reduction may be due to vocal cord polyp. Why? How?
Since the vocal cord can't completely adapt the false cord, maybe take X-ray.
It's very unlikely. Now, muscle tension, you are talking about muscle tension dysphonias. Muscle tension dysphonias actually give rise to structural lesions, not the other way around. Okay. Which is the actual, structural lesion which is secondary to muscle tension dysphonia actually?
It can be vocal cord cyst and polyp secondary.
It is not cyst, it is actually it is not polyp or cyst, it is actually nodule. Nodules are usually secondary to type 1 muscle tension dysphonia. Nodules. Again, there's one more point I thought, I think, okay, what do you do with when the treatment was discussed, you were asked about treatment, you talked about microlaryngeal surgery. Anything else is important here in this particular case? I saw the laryngoscopy finding. In this particular case, what do you do with the specimen?
Definitely send it for it.
Yeah, you should specify that. Vocal cord polyps can actually harbor malignancy. Always say that I will send for histopathology examination. Okay. Okay, right.
Do you know what is now that we're talking about this, about whether there's harboring money, do you know what is the donut effect?
Donut effect is seen in infiltrative lesions of vocal cord. When we do hydrodissection, the surroundings of that infiltrative lesion will swell up, while the infiltrative lesion will be pushed down.
It will not rise. That is okay.
Any questions? Or we can go to the next case. Jirs madam and Rena madam, your opinion?
We can go to the next.
Thank you, Febina. Good presentation. Overall, you have done.
Yes.
Presenting the next case also will be presented.
Madam, she is presenting the next case also. Yes.
Yes, okay.
She's only presenting the next case.
Yes, ma'am.
Please talk louder, no?
Okay, madam.
Okay, right.
Presenting the case of
The other presentation.
Presenting the case of Maya, a 42-year-old female coming from Mangalapuram, Thiruvananthapuram. She is a hotel entrepreneur. Her presenting complaints were right-sided nasal obstruction of 6 months duration and history of present illness. Patient presented with complaints of right-sided nasal obstruction for the last 6 months, which was gradual in onset and slowly progressive. And the nasal obstruction was continuous throughout the day, and it was aggravated on exposure to cold and relieved partially by using nasal drops. And there was also complaints of postnasal drip, which was more during night, and there was intermittent right-sided facial swelling, which subsided taking medication. She has no complaints of absent or reduced sensation of smell or facial pain or nasal bleeding. No complaints of swelling of eyelids, double vision or blurring of vision. No history of fever, headache or vomiting. No complaints of any earache, ear block sensation or hard of hearing. Seek dental pain or loosening of teeth. Past medical and surgical history. She has underwent thyroidectomy 3 years back and on thyroxine supplements. There is no history of bronchial asthma, tuberculosis, diabetes mellitus, hypertension, coronary artery disease, or seizure disorder. No history of any drug allergy.
You said swelling of eyelids. Is it really only swelling of eyelids? Yes, you will look for swelling of eyelids, but what exactly are you looking for? Swelling of eyelids is different from what you're actually, other thing that you're looking for. You are obviously seeing whether this lesion is involving the orbit, right? That is why you're asking these questions.
Yes,
So what, can you go back to that? Yeah. So what exactly are you looking for?
I'm looking for any intraorbital complications.
Correct. So will swelling of eyelids give you intraorbital complications? Swelling of eyelids is a preceptor thing.
Preceptor.
So that is not telling you what is happening inside the orbit. It is telling you what is happening in the preceptor space in the eyelids. For example, if there's allergic rhinitis and patient has got itching of the eyes and all, you may land up with swelling of the eyelids or what they call allergic shiners in patients. What you're looking
Even
for
allergy,
exactly
allergy
is
itself will cause that puffiness of the eye. Are you
yeah.
talking about that or something else?
You're looking for protrusion of the eyeball. You're not going to, you in history, you'll not use the word proptosis because it's a medical term, but you'll say that whether there's protrusion of the eyeball. That will tell you that there's something happening retrobulbar inside the orbit. Okay, so swelling of eyelids is one thing. You can ask for that, but you must look for protrusion of eyeball. And how do you make out even a slight degree of protrusion? When you're examining, or let's talk about when you examine. We'll go to that.
Examiner stands behind the patient and the patient head is extended and look for any extension of eyeball beyond the orbital margins.
Correct. So you look at it tangentially along the forehead from the superior aspect of the patient. Correct. Go on.
Right. Personal history, she takes a mixed diet, sleep and appetite normal, bowel and bladder habits were regular and no addictions. Family history, there is no history of any bronchial asthma or allergy in family. Socioeconomic history, she belongs to upper middle class family according to modified Swami scale. And on examination, general examination, patient is conscious and oriented, moderately built and nourished. There is no pallor, icterus, cyanosis, clubbing, lymphadenopathy or pedal edema. The BP was 130 or 80 millimeters of pulse rate, 76 per minute. Examination of nose and paranasal sinus. External nasal framework normal. Cold spatula test, there was absent fogging on the right side, and Cornell's test was negative bilaterally. Columella was central and vestibule was normal. And on anterior rhinoscopy, on the right nasal cavity, there was multiple pale glistening masses just touching the floor and anteriorly reaching just behind the anterior end of inferior turbinate. And on probing, these masses were soft in consistency, insensitive to touch, not bleeding of touch, and the probe could be passed all around the mass except the lateral wall. And on the left nasal cavity, there was inferior turbinate hypertrophy, the inferior meatus, the middle turbinate, middle meatus, the floor were normal. And on posterior rhinoscopy, the posterior end of septum and turbinates were normal. Bilateral eustachian tube orifice was normal. Fossa of frozen color is also normal. The roof and posterior wall of nasopharynx showed mucopurulent discharge. There was no paranasal sinus tenderness. The examination of face and orbit, there was no proptosis, no obliteration of nasofacial groove. Facial sensations were normal, and vision and extraocular movements were normal, bilateral. Other ENT examination were normal except for neck showing a thyroidectomy scar. And the systemic examination was also within normal limits. Summary.
So, talking about examination, you said you did posterior rhinoscopy, right? Can you go back to that slide? Yeah. Now, all this posterior end of septum, turbinates, bilateral eustachian tube orifice, fossa of Rosenmuller, roof and posterior wall of the nasopharynx, can you see them with an endoscope? Yes or no?
Yes, ma'am.
Yes, you can see them with it. So if you are, so posterior rhinoscopy was an examination, it's unpleasant for the patient, right? It's not very comfortable for the patient. So that we used to do it when there was no endoscope. Now that you can still do it, suppose for example, there is no endoscope in the OPD, you can still do posterior rhinoscopy. But if you are able to do a endoscopy, then there's no need to repeat a posterior rhinoscopy. Does that make sense? Yeah. So you'll only do it if at that particular moment or in that particular place you don't have an endoscope. Then of course you will do. But otherwise, all that you can see on posterior rhinoscopy, you can see very well with an endoscope as well. Cottle steps was negative on both sides. And fogging of the nose was equal on both sides.
No, madam, it was absent on the right side.
Just show me your slide. Okay. 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 Is there any history of sneezing, watery rhinorrhea? You said no, I think. No, there isn't any history. Any history in the past?
No.
Okay. Why am I asking you this? Why do you specifically in detail ask this? Whether the patient has watering, rhinorrhea, sneezing?
Or any history of allergic rhinitis, which may be a predisposing factor.
Predisposing factor for?
Development of chronic rhinosinusitis.
No, I can't hear you. Can you hear?
No. Allergic rhinitis, of course, yes, it's a predisposing factor for chronic rhinosinusitis. But here, madam is asking you why you want to know history of allergy, nasal allergy in this patient. Is your patient asthmatic? No, right? You said no. There's no history.
No.
Okay, go back to your summary. We'll come back to this, I think, in some time. Okay.
42-year-old female presented with complaints of right-sided nasal obstruction associated with postnasal drip and intermittent right-sided facial swelling of 6 months duration. And on examination, pulse spatula test, there was absent fogging on right side. And on anterior rhinoscopy, there was multiple pale masses in the right nasal cavity, which on probing was soft in consistency. insensitive to touch, not bleeding on touch, and drop could be passed all around except the lateral one. All other ENT and systemic examination within normal. Diagnosis, chronic rhinosinusitis with polyposis.
What polyposis do you think? Because that you may have to specify, what polyps.
Localized disease. Localized disease.
You get any generalized disease in polyps, nasal polyps? Where do you think they are arising from? Which sinus are they arising from?
From the maxillary sinus.
I can't hear you.
Maxillary and ethmoid sinus.
So they're arising both from the maxi and the ethmoid sinus, or they're primarily, what are they primarily arising from? Ethmoid sinus, maxi sinus, what
Ethmoid
sinus? So what are those polyps called?
polyps.
Ethmoidal polyps. And when there's a polyp arising from the maxi sinus, usually what is it called?
Antroquinal.
So you think, between the two, what do you think this is? Antroquinal polyp or ethmoidal polypus? Loudly.
Ethmoidal polyp.
Ethmoidal polyps. So what is the etiology of ethmoidal polyps? What is the predisposing factor for ethmoidal polyposis?
Allergy is predisposing.
Correct. That's why we were asking you about allergy. That is why we were specifically saying, especially when we saw the endoscopic picture. Now, let me ask you a very basic question, which we ask undergrads. How do you differentiate between an antroquinal polyp and an ethmoidal polyp?
Actually, ethmoidal polyps grow anteriorly, and antroquinal polyps grow posteriorly. Antroquinal polyp is usually seen in children, and the etiological factor is infection, whereas ethmoidal polyps is usually seen in adults, and the etiology being allergy.
What about the shape?
There are multiple points. You've told us two.
Multiple polyps will be seen in ethmoidal, and the single polyp is in antroquinal.
Some more points of differentiation.
What are the parts of the antroquinal polyp? It gets its shape because of the parts that it's got, right?
So, neck,
No, it has an antral part.
antral part, spinal part.
And what comes anteriorly is called? It comes out through the nose, so it's called?
Nasal.
So what is its shape now?
What madam is asking, there's a typical word for that shape of the antroquinal polyp.
Because Renuka ma'am specifically said it's an undergrad question, so that's how we teach undergrads, right?
Called trifolate.
Three parts, right? Trifolate.
Three parts. It's called trifolate. How do you describe ethmoidal polyps? What is the classical term used?
Small grape-like masks.
Cluster of grapes.
Cluster, bunch of grapes. Okay. What is this about this mass which you think may not be? What is the thing which goes against it being an ethmoidal polyp? I agree with you that it looks like an ethmoidal polyp, but what are the things which are going against it?
Actually, ethmoidal polyps are bilateral.
Correct. So that's another differentiation point between antroquinal polyp and ethmoidal polyps. And you said there is no history of allergy. Patient has no history of allergy.
So given those points, what are your differentials for this case?
being a unilateral mass, differential diagnosis can be allergic fungal rhinosinusitis.
Go on.
Sorry, madam.
Go on. That's one
Continue.
difference.
And those are can be inverted papilloma. Appearance is not typical as that.
So you can justify later on. First, give us a list of different nasal masses unilateral. Then you can tell us why it is not this or that. First, tell us what are the relatively common unilateral nasal masses that you can get.
Allergic fungal rhinosinusitis, inverted papilloma, sinonasal malignancy, sinusitis of any dental origin,
Little rarer ones. That can present as a nasal mass. You're right. You told us the relatively common ones. What are the rare ones? Something coming from the brain.
meningoencephalocele, olfactory neuroblastoma.
Olfactory neuroblastoma. Any bony masses?
Osteomas.
What is osteomas? Anything else? A bony condition which can involve either one bone or multiple bones. Can be monoostotic or polyostotic. No, I can't give you any more clues.
Yeah, I think the answer is so straightforward. Sometimes there can be some syndromic association also with it. Anyway, that's a difficult clue. Monostatic. Ah, got it. Yes.
Fibrous dysplasia.
Good.
Okay. Okay. Why don't you think this is a malignancy? You think this is a malignancy? You think it's adenocarcinoma or squamous cell carcinoma? Do you think? In your case, do you think it could be that?
The chances very less, man.
So no, you don't think so, right? Why?
Why not?
The age of the age of the patient, and the sinonasal malignancy is more common in males.
More
and
common
also
in?
the typical appearance male, and the appearance of the mass, and usually there will be a history of any bleeding or blood stain discharge. Sinonasal malignancy.
Also, more important, I mean, very important, which may be, which is involvement of surrounding structures, right? Infiltration into the orbit may cause medial rectus paralysis, may cause lacrimal fossa involvement, so epiphora, may cause proptosis, may infiltrate into the brain. So all that is not there. There are no cervical lymph nodes. So all this you should tell us. There's no cervical lymphadenopathy. What you told me is yes, that it is not bleeding. Why do you think this is not an inverted papilloma? Could it be an inverted papilloma?
Inverted papilloma usually presents as a unilateral mass. Typical appearance is leafy, lobulated, pinkish mass.
Yes.
There can be bone erosion and elevation to surround.
Gender?
common in males.
Which decades of life?
40 to 50 years.
Is there any, we haven't discussed yet, but we'll come to that later. Okay.
What is the consistency, Febita, of inverted papilloma?
Firm in consistency.
Yeah, that's also there.
How can you differentiate a mass from a mass like an meningoencephalocele? Clinically.
Clinically, on probing, we can pass the probe all around the mass, and we can elicit impulse on coffee.
You can't pass the probe all around the mass necessarily. If it has a wide opening superiorly attached, you will not be able to pass it superiorly. You will not be able to pass, but yes, one is impulse on coffee. That can be there.
What is that sign called when you have a
Trustenberg sign.
Yes.
So your diagnosis should be nasal polyposis with chronic rhinosinusitis. If it was allergic rhinitis, you would have said allergic rhinitis with nasal polyposis. Because the chronic rhinosinusitis is the effect of the nasal polyposis. It's not the etiological factor of the ethmoid polyps. So you would say nasal polyposis. I would go so far to say ethmoidal polyposis with chronic rhinosinusitis. Yeah, because it's very classical. The picture, the image is quite classical of ethmoidal polyps. The only thing, like we said, which goes against it is that it's unilateral. Can you get a unilateral AFRS? Can you get unilateral ethmoidal polyps? Yes, you can. So it is possible. You've forgotten a couple of more masses. One which can bleed.
Sinonasal malignancy.
That you already told us. You're not told us of one or some more masses which can, where they will present with a mass and bleeding.
Hemangioma.
Okay, one is hemangioma, you're right. Hemangioma, hemangiopericytoma, all these bleed. Plus there are something else.
Certain endemic areas, Shebina?
Rhinosporidiosis.
Yes, you should be able to tell me, no? Kerala is endemic for rhinosporidiosis. And of course, this is a female. If it was a male,
Adolescent young male.
Shebina?
angiofibro. Okay. Ma'am, do you have any questions? Sorry.
No, madam, I'm just asking whether it's a typical rhinosporidial mass. What will be the finding?
There will be a pinkish mass with polypoidal surface with white dots or
It's like you said, ethmoidal polyps are cluster of grapes. This looks like a
Which berry?
What is that appearance?
mulberry.
Which? Not mulberry. Which berry? Some
mulberry
other
is
berry.
black. What is it? Red with dots on it. Which berry?
Strawberry.
Ah.
Okay.
Yes. Okay. I don't know what it is with doctors. They're always comparing everything to food.
ENT surgeons, I think we are food lovers.
That's the reason, madam.
From berries to cheese, everything we have.
Can we go ahead, madam, with this, or do you want to ask any more differentials?
No, we'll go ahead. We'll go ahead. How will you evaluate this case, Fabina? Go ahead.
Complete my examination with a diagnostic case endoscopy. Know the extent of the lesion. And I would like to, since my diagnosis is nasal polyposis with chronic rhinosinusitis, I would like to start the patient on medical management. So prior to
Will
that,
you do the diagnostic endoscopy in the OPD, or you'll take the patient to the OT?
the OPD.
This particular patient you'll do in the OPD or OT?
Usually do it.
Talk loudly, can't hear.
We usually do it routinely in our OPDs.
Okay. When will you decide that you will do this DNE not in the OPD but in the OT?
It is a bleeding nasal.
Okay. So if there's history of bleeding, you will not do it in the OPD. You will not even probe the mass. Even if there's no blood clot, no bleeding, but there's history of bleeding, you will not probe the mass. You will not do a DNE in the OPD. Okay, go on. So first you will do a DNE. Then
Start the patient on medical management. That is a trial of
No,
steroids.
no. What investigations? You have to first confirm your diagnosis, right?
Confirm the diagnosis. I would like to do CT scan and paranasal signs.
will you do with contrast, without contrast?
Without contrast.
Okay. When will you ask for a CT scan with contrast?
We are suspecting infiltrating lesions like sinonasal malignancies, inverted papilloma. We suspect any complications.
Why exactly will you do it in sinonasal malignancies? What exactly are you trying to see with contrast?
Contrast is for what?
To see any hyperdense areas.
See, if this lesion enhanced with contrast, what would it tell you? What are the lesions which enhance on giving contrast?
See or any vascular lesions.
Okay. So you want to one see the vascularity of the lesion, right? And then depending on the vascularity, you can sometimes which vascular lesion can you diagnose only on CT scan? You don't do anything else. You don't do a biopsy. You may not even do a diagnostic nasal endoscopy. Just on CT scan with contrast. Yes. Nasopharyngeal.
Angiophyte.
Correct. No, I'm asking you, when will you decide that, yes, now in this patient, I have to give contrast? One is vascular lesion. You're right. There's history of bleeding. When you look at it, you see that it is very red. It looks vascular. Anywhere else you will do besides this, even if it is not vascular, let's say, even if there's no history of bleeding, still you will do a contrast. So anything going outside the sinuses, if it is involving the orbit, if it is involving the cheek, if it is going outside the boundaries of a sinus into surrounding soft tissue, including the brain, you will do CT with contrast. That is one investigation. What is the other investigation you can do if this happens?
Paralysis and sinusitis.
No, we can't hear you.
MRI of brain and paralysis signs.
MRI with or without contrast?
With contrast.
With contrast. So some time ago, we were talking about inverted papilloma, right? So radiologically, can you make out the difference between anthropoidal polyp and inverted papilloma, or ethmoidal polyps and inverted papilloma?
Inverted papilloma usually shows a convoluted cerebriform appearance. CT scan.
And what else? One is they have a cerebriform pattern. Something
Bone
else?
erosion. Bone erosion and expansion.
Well, more than bone erosion, what is there? How do you make out that a particular, where its origin is?
Hyperostosis.
Hyperostosis at its origin, yes. So anything out of the sinuses, you will do a CT scan with contrast and an MRI. Why is it that anything going into the brain, you must definitely do a MRI? Even if you do CT with contrast and you can see it very well, the whole thing, you will still do an MRI. You may not do an MRI if it has gone into the cheek or even into the orbit. You may not do an MRI, but in brain, you have to do. Why?
MRI is more sensitive for detecting soft tissue lesions. To look for any meningeal neural enhancement.
What is the most important reason? Which a CT with contrast will not show you. And only an MRI with contrast can show you.
Thrombosis.
What?
Thrombosis.
No, you can see a signal void in CT scans also. In yours, sigmoid sinus thrombosis, you get that delta sign. So you can see that thrombosis in CT. The thing you can't see is the relationship of the mass to the internal carotid artery. In CT with contrast, the artery will also be white and the mass will also be white. But in MRI, the mass will take contrast and look white, whereas the carotid artery will look black because of a high flow void. So therefore, to make out the relationship of that mass to the carotid, it is very important to do MRI with contrast. Okay, madam, you can ask what I've been talking to now.
Yeah, proceed. How will you? You've done your scans, then what next?
Scan the diagnosis of chronic rhinosinusitis.
Yeah, you confirmed your diagnosis. It is nasal polyposis with chronic rhinosinusitis. So how will you treat this patient?
Like to start the patient on oral and topical steroids.
You don't want to do any blood work at all for this case. You didn't talk about it. Yeah.
So I'm planning start on steroids. Like to
1 minute, Febina. Febina, you don't want to do any blood work on this patient at all?
Yes, madam.
So what kind of blood work you want to do?
Blood sugars.
Why blood sugar?
What all investigations, Febina?
See, you said two things. One is your imaging studies you spoke about and your diagnostic nasal endoscopy. What other investigations you will do?
What are the usual blood parameters that we take?
Complete blood count. renal function test, liver function test, routine random blood sugar.
How will you evaluate allergy?
Absolute eosinophil count.
Madam is asking for one more blood test at least. This is specific for patients with allergy.
Absolute eosinophil count.
For allergy,
Serum IgE.
Serum what?
IgE.
what allergic test, Febina?
Madam, serum IgE can be done.
Then
Skin prick test. Skin prick test.
blood
Radioallergy sorbet test.
Okay, so what treatment options you will offer this patient?
First, I would give the option of starting oral steroids. This patient.
So what will you
Actually,
give? Tell the full answer. What
tabs,
is your preferred drug? What is the dose? Everything. Yeah.
Patient is started on tab prednisolone 0.5 mg per kg per day for 5 to 10 days, which will be followed by intranasal corticosteroids, omeprazole furoate, fluticasone sprays. Other options are
What dose of intranasal corticosteroids will you give?
we are using omeprazole furoate spray. It's given at a dose of 200 microgram per day.
No, but you will tell the patient like this, you take 200 micrograms per day.
Each puff is 50 microgram. So advise him to take one puff each nostril twice daily.
Go on.
How do corticosteroids help? I mean, how do they work?
It reduces inflammation by reducing the production of pro-inflammatory cytokines.
Go on. What else?
Other options treatment are immunomodulatory antibiotics like doxycycline at a dose of 200 milligram first day, followed by 100 mg once daily for 20 days.
You're going to give immunomodulatory antibiotics, you give them only for 20 days?
Can be given up to 3 months.
Suppose you give doxycycline, suppose you give, what is the other antibiotic which is commonly given as an immunomodulatory antibiotic?
Macrolides.
Macrolides.
Azithromycin 150
Yes.
mg once daily.
So how long do you give?
3 months. 3
If
months.
they're at least 6 months you would give. If you're thinking of an immunomodulatory role to them.
Azithromycin, clarithromycin and all you have to give for long. It's not enough if you give for 15 days.
Other options biologicals, monoclonal antibodies.
So are you going to, is this going to be your first line of treatment, that you will give steroids, then you will give immunomodulatory antibiotics, then you will give biologics? Is that how you treat ethmoidal polyps routinely?
Don't we operate?
You know how much biologics cost?
We'll talk
So
about, and there are still emerging treatments. We'll talk about that later. What do we do routinely? You talk about
what
that.
is the routine treatment for ethmoidal polyps?
After maximum medical therapy,
Hmm.
So
assessment
maximize medical therapy, right? How long? What is the duration? That means you will try medical.
for 6 to 12 weeks.
3 months. Okay. After that, what will you do?
After that, if there is no symptomatic improvement, there is no reduction of polyps by endoscopy, we will proceed with the surgical
No,
management.
I didn't follow. What was the last thing you said?
She says
There is
after.
no there is no symptomatic improvement for the patient, or by endoscopically there is no reduction of polyps. It is the
Do you think that can happen with oral steroids, that there'll be no improvement? Can it
sometimes
happen in ethmoidal polyps that if you give
for
oral steroids, that the patient will not show any improvement?
extensive polyposis, some patients do not show improvement.
Okay, carry on. So if it doesn't show improvement, then
And proceed with surgery, endoscopic sinus surgery. For that, all preoperative
Please, Febina.
and proceed with an endoscopic sinus surgery. For that,
What are the goals of sinus surgery in this particular case? What will be the aim of your surgery in nasal polyps?
reduction of the load of polyps to improve the uh, delivery of medicines to the
Yeah.
sinus,
So one is to relieve nasal obstruction. Then
or improve the delivery of medications.
so
That is
access for topical medication. What else?
preserve the normal sinus mucosa as far as possible.
Okay. And if there's something that is obstructing the drainage of the sinuses, you want to get rid of that and improve the sinus drainage as well, right?
Right.
So what will you do for this patient then?
So, I will an endoscopic sinus surgery, preferably under general anesthesia. For that, all preoperative blood investigations like complete blood count, renal function test, liver function test, bleeding
that's
parameters
all
like
you've talked about. You've talked about that. Go on. So now you decided to do surgery. Patient is under anesthesia. What will you do?
for this patient for endoscopic sinus surgery.
Yes, yes, yes.
Steps. Go on with the steps of surgery.
First, the nasal cavity will be packed using lidocaine and
So you
adrenaline.
decongest the nose, right? What will you use to decongest the nose?
Lidocaine and adrenaline.
Percentage, everything you have to say. You have to be very specific in your answers.
Can use 30 ml of 4% lidocaine with 5 ml of 1 in 1000 adrenaline.
Yeah, I suppose varying percentages. As many doctors, there are that many percentages. So we'll leave it at that. Okay, go on. Then you'll decongest the nose. After you decongested the nose,
Local infiltration will be given.
for that, what infiltration, what concentration will you use?
1 to the ml of
1:1.
1 in 80,000 adrenaline.
No. I know 1:80,000 dentists use, but we don't use it. What will you use? You'll get so much tachycardia and bleeding that the adrenaline will be of no use. What is the percentage of adrenaline? So this is not controversial. Everyone uses the same percentage.
1 in 1,000.
1 in
1,000?
1 in 1,000 is the ampule. That whole ampule is 1 in 1,000. It's pure, what we call pure adrenaline. It's 1 in 2 lakh. 1 in 2 lakh xylocaine with adrenaline.
What percentage of xylocaine you use for infiltration?
1%.
No, madam is asking what percentage. There is 2%, 4%, 10%. Which percentage of xylocaine will you use for infiltration?
2%.
And what will you use for topical?
4%.
And in your last case, which you were talking about, what percentage will you use? Vocal polyp patient. After the surgery is done. Since we are talking about xylocaine. So in the larynx, if you want to spray the larynx.
10% spray. 10% spray.
Remember one thing, the examiner can ask you, okay, dose of xylocaine, safe dose of xylocaine with adrenaline, without adrenaline, you have to know those. Do you know that?
Milligram per kg body weight, you should know the calculation.
Adrenaline we can use up to 7 milligram per kilo.
That is with adrenaline.
With adrenaline.
And without adrenaline?
3 to 5 milligram.
Good. Okay. So you want to infiltrate. Okay, then what will you do?
First step is uncinectomy.
Go on.
After uncinectomy can be done using backbiting forceps, and the maxillary ostium is identified, and uncinate is here, and the maxillary ostium is widened. Then proceed with anterior and posterior atherectomy. If there is disease in sphenoid and frontal sinus, we'll do sphenoid or frontal sinus clearance.
How many approaches are there for the sphenoid?
3, madam. Lateral, medial, and intermediate approaches.
Lateral, medial, and
Intermediate approach.
which one would you like to choose?
Medial approach.
Okay. Do you know how to do an intermediate approach?
Is done by penetrating through the middle turbinate posteriorly.
There's a particular landmark, but okay, we'll take it that we do it. Is there two different types of ways of approaching the frontal sinus? Have you heard of intact bulla technique? Have you heard of it?
Sorry.
Do you want to talk about it? Okay, there are two approaches. One is called intact bulla technique and the other is called bulla down technique. That means you remove the bulla and then find the frontal sinus. In one, you keep the bulla intact and find the frontal sinus. Okay. Madam, you want to ask him more surgical questions or we ask post-operative care now?
We'll move on to the post-operative care now.
So will you put a nasal pack?
Yes, ma'am.
Okay, when will you remove the pack?
Usually the next day.
What will you use to pack?
Then Virocell. Usually here is Virocell nasal pack. We can use gauze packs.
Have there some absorbable packs come now that you can put in the middle meatus? Do you know the names of any of them? Okay, so you remove the pack after 24 hours. Then what will you do?
The patient will be assessed for vision and extraocular movements. Then proptosis should be looked for. Then after
That you won't look
there is
after
no
24 hours. All this you'll look after immediately after the surgery, right? Okay. Then
then we can start the patient on nasal douching, saline nasal douching should be started.
what will you put in the douche?
Sodium bicarbonate,
How much? Patient will ask you. So you tell me exactly how you will tell the patient. Let us assume you tell him to make the solution at home. Maybe he cannot afford commercially made solutions. Then what exactly will you tell the patient? Do this, do this. You have to explain to him what to do.
soda and salt should be
Soda and salt. Where should it be put?
What
what?
proportion?
So first of all, you say you'll put it in water, right? Which soda? Washing soda?
baking soda.
Khane ka
Baking
soda. You'll have to tell them in whatever language, you have to tell them the soda that we eat. Others he'll put washing soda in that. Okay. Now madam is asking what proportion. Suppose there's a glass of water.
So water. 5 teaspoon of salt and 1 teaspoon of baking soda.
In a glass of water?
No, no. Not so much.
Exact proportion I don't know.
1 level teaspoon of salt and 1 pinch of soda. Okay. Not 5 teaspoons. He'll come running back to you. Okay, so nasal douching. Then what else will you give him?
Patient will be restarted on intranasal corticosteroids to prevent recurrence of the polyps.
Will you give oral antibiotics? Post-operative, you'll give oral antibiotics. You'll do nasal douching, right? Would you like to give post-operative oral steroids? I think she's off the net.
She's frozen actually.
Yeah.
Madam, power supply is gone. Power supply is gone. 1 second. Hello?
Yes.
Am I audible?
You are audible, yes.
Madam, the power supply is gone. Wi-Fi is off. I'll just correct it.
Okay. Madam, hello, can you
Ma'am?
hear me?
Yes, ma'am, I can hear you. Yes.
Ma'am, I will have to leave
Just a
by
second,
9
ma'am.
o'clock, huh?
It's getting connected now.
If that is okay with you.
Yes, ma'am.
Yeah,
Not
okay.
an issue at all. You got about 10 minutes. We'll try to wind up.
Yeah, yeah. No, I am here till 9 o'clock, but at 9 o'clock I'll have to leave. I have one prior commitment at 9:15. So I have to reach there in time. That's why.
Anuraj, is it okay?
Madam, we are connected, madam. We are connected. Yes, ma'am. Yes, ma'am. Video.
Hello.
Febina, you have in online. Okay. Madam, you can
Technical issue.
please start, madam.
Yes, Fabina, continue. Will you give steroids also for this patient after surgery?
Intranasal steroids will be given.
So
I
when
can start
you
my video again. It says I can't start my video because the host has stopped it.
But it's the same here.
Carry on, Fabina. I can hear you.
oral steroids will you give after surgery? Post-operatively.
Steroids can be given to prevent recurrence, madam.
For how long?
Take a guess.
What will you give dose? How long?
3 weeks. 3 weeks. At a dose of 0.5 mg per kg per day.
Is there any other thing you'll do besides medical line of treatment after endoscopic sinus surgery? And you're giving all these medications. Is there something else you will do besides this post-operative? Let's say 1 week after surgery. Would you like to again do a nasal endoscopy, clear the clots, crusts, etc.? Make sure that it is healing well.
Yes, ma'am.
Yes. So
Yes, ma'am.
ideally you should do, may not always be possible in a very busy government hospital, but ideally you should do an endoscopy after 1 week to clean the clots, crust, so that no adhesions form.
Okay.
Do you know what the healing, when there's healing of the sinuses, you will see some amount of edema, which looks almost like tiny polyps, but it is not polyps, it's just healing. You know what that term is called for that? It's called cobblestoning. Remember, okay? It's called cobblestoning. That is the normal edema of the membrane. It is not polyps.
So I think now you can tell us about the, emerging therapies. What is the role of your biologics and what are the things that you can tell us about that also for nasal polyps?
Biologics are emerging Malsumab, which is an anti-IgE. Hello.
Yeah, please, we can't hear you.
Louder, please, Sabina.
Omalizumab, which is an anti-IgE monoclonal antibody. Then examples are dupilumab, which is an interleukin, anti-interleukin 4. Then lepolizumab.
What is a biofilm?
Biofilms are polysaccharides which are secreted by the bacteria, which forms a protective cover over the bacteria and renders them immune to antibiotics.
So if you have a stent or something in the nose, then you can get biofilms collecting on top of that. How do you treat patient biofilms?
Did you get the question? You could hear?
Yes, madam.
Okay.
Okay, just tell us how long will you use intranasal corticosteroids? And how long will you follow up this patient? Let's talk about something.
Given intranasal corticosteroids can be given for from 6 months.
And what will you tell the patient about follow-up?
Monthly follow-up.
For how long? Monthly follow-up. They're known to recur, no? So you want to keep a watch. Okay, answer one question for me. If ethmoidal polyps recur, then why is it that you should operate them at all?
Improve the drug delivery to the sites.
Yes. So what will happen with this drug delivery?
By obstruction.
So it will keep the patient symptom free. Yeah. And whatever small polyps come up, the drug will take care of it. There is recently thought of adding steroids to the douching, nasal douches. What
Which
steroid?
steroid?
Yeah, madam is asking.
Which steroid is added to the douche?
Budesonide.
Okay.
But budesonide, people are also worried about what when they give budesonide nasal douche or a budesonide nasal spray. Earlier, we used to use a lot of budesonide nasal spray. Now we use fluticasone and mometazone. Why budesonide is not?
Cancer. Candidiasis.
Not candidiasis. Candidiasis. Yeah, okay. What else? Hypothalamus. What happens?
Pituitary axis.
They say it's that suppression is more with budesonide. So that's why that is the concern with budesonide. Ma'am, Pushpa ma'am, Jayaprabha ma'am, anything you want to ask her or shall
Madam, any other question, madam? Is it okay?
Renuka ma'am?
Yeah, I think
Ma'am, we have to give her a small feedback. You done fairly well, webinar. You done quite well, webinar.
Febina, you seem to know most of. Sorry, I interrupted you.
You've answered most of the questions, but sometimes you may get a little. When you answer all the questions, you will get a little more. So you need to read up on whatever you didn't answer today. That's it. Otherwise, you've done fairly well, ma'am.
Yes, I think she answered most of the questions. But only thing is you need to be a little louder and clearer, because what can happen is you may say the correct thing, but if the examiner doesn't hear it, then they will keep asking you the same question. And you will think in your mind, I have said it. And the examiner is thinking in his mind that she hasn't said it. So this common confusion happens if you don't talk very clearly. So make sure you talk clearly and loudly. Also, it gives the examiner a feeling that you are confident. So that is important. Your body language, the way you talk, the way you communicate is important, not just knowing it, not just knowing the information, but how to communicate that information. Okay. So you should sit up straight, loud voice, eye contact. Okay. These things make a difference. Your knowledge is pretty good. Some lacunae are there. So you go through, you must know.
You got still almost a year for exams, right? You're now just entered the final year.
And the standard, sorry.
December, right? December or January, you'll appear for exams, right? When will you appear for exam?
Webinar?
July.
Okay.
I have
Webinar,
exams
we are
in
not
July.
there now.
Okay.
And common surgeries, which are routinely done, you must know the steps properly. Because unlike an undergrad where we are not asking them questions because they're becoming a surgeon, they're just becoming GPs. But at postgrad, you're becoming a surgeon. So the examiners will ask you details of operative steps of most of the common surgery. So it is a good idea to write down those steps of each surgery and then take them to your teacher so that she can correct them. This is missing or this is added, so that you have a ready-made note in your mind as to when you are going to answer that question, because this question about how will you do this surgery will come up. Yeah. But otherwise it was good. Good effort.
Thank you.
So thank you, Fabina. It was both the presentations were good, and all the best.
Thank you so much.
Any examiners in the audience to ask questions or give feedback?
Thank you so much, Madam Renuka Madam and Vijayalakshmi Madam for a good experience for students. Thank you so much.
Thank you so much for inviting me.
Thank you very much for inviting me. It was
Thank you.
It was
Thank
a
you,
pleasure.
madam, for your presence and for your comments.
Thank you, ma'am.
Okay, Madam. Thank you.
Right. I'll leave the meeting now.
Yeah. Thank you, Madam.
Okay.
Bye.
Bye bye. Bye.